would be okay. So, oh, I'm in. Oh, you're in. Hi, I'm hanging up. Can you hear me? You're muted.
There we go.
Yep, there you are. Now you're good.
I'm gonna clean up my office.
Yeah, so I talked to her today and she sent me, I'll send you the report. She sent me a report. Looked good. I told her what I thought.
Yeah, I mean, I'd like to see her comments because I want to evaluate
Yeah.
all of us, you know.
I have everything here. I wanted to take a good look at them. She didn't have, she was happy, for the most part. With,
but I mean, she should be happy, but you should be happy. It was
I'm not happy because I'm not happy with a few things. I just didn't feel like we were prepared as much as we should have been. Vicky I should have, or you should have, or somebody should have updated Vicky on a few things, which I didn't even think about it, because again, I'm the type that, and it all falls.
Oh, I'll take that one on because
me too.
I didn't have her send her slides to me for review.
But that's not even the thing. I would be asking like what's new with the company. Go on the website. She would have seen the Medicare. She would have seen the sign in if she had done it. So that's not. I don't blame Vicky. I blame myself because. Well,
and I agree with that, but I think that should be more on me because they were my recruited.
It's on us.
Yeah, my recruited speakers, and they should have been,
brief. Again, the hop-in, we should have had instructions beforehand that we should have had more practices. I should have had more, I should have had more control and more autonomy.
I think what happened with hop-in is when we practiced, it didn't work, and then we never got the group back around to say, okay.
But if I had known how to use it, or I had the kind of access in the back end that Kristen had, then I could say to you, Chris, let's get on. Let's see if we could figure it out. So, and we would have, because that's what we do. So, I don't blame anybody.
We got distracted by a lot of emails about hop-in and backstage and this and upload your slides. And where I misstepped was be like, I need to see your slides before you.
We can't expect that they're going to do what they do. We can't. And that's a shame, but that's my fault.
That's a good lesson learned though.
Yeah.
But I have to say, even with that, Vicky's talk went off very well.
I thought so. Did you? Because Kristen said that there was only one complaint about her. It was all positive. One complaint was that she said a lot. Did you notice it?
That was Barry.
Yeah, that's what I thought.
That was not Vicky.
Yeah, I didn't think so.
Vicky was extremely articulate. I think they got that wrong. They probably were. Barry said 100,000 times.
Yeah.
Vicky did not. I listened to Vicky.
Did Barry finish the demo?
Yeah, I think so.
Okay, because you weren't going to do. I think Harrison. Harrison
Jones is in.
Harrison, do you have gray hair? No, it's the lighting. It's the lighting in my room. I can't hear you. Unmute yourself.
I've got some.
Oh, there you are. You got a little bit.
I've got a little gray hair. I'm good. How are y'all?
Good.
Thanks.
So basically, I'm going to let Chris take it from here. My job is to get you guys on, and then critique you when you're done and everything.
Do we have any idea of number of registrants or?
Yeah,
interest?
there's I could tell you exactly. Give me 1 second. There is registered. We have 227.
Oh yeah, so that typically ends up to be about 111.
Yeah,
it's usually about half. A lot of people register and then about half come on, but that's okay.
All right.
And then I'll just do I kind of try to do it like a podcast, like we're just, you and I are old friends and we're getting together and I'm introducing you. And this is an exciting new area. I'll talk about, the design and invention of the IA adapter coming from Duke University. Is there any specific people you want me to reference on that?
Not really. Just
okay.
me.
Okay. I didn't know if you
I mean,
had any, I didn't know if you had any other people on the actual invention itself, biomedical engineers or anything.
Not really.
Okay, that's good.
Yeah, that is good. Harrison, do you want to try sharing your slides? You use Zoom, I'm assuming before, lots of times, right?
Yeah, but I always should practice here.
Okay, cool.
And Harrison, are you, I have you as associate. Have you moved up in the ranks? Or are you still associate professor?
I'm still associate.
Yeah, okay. I just want to make sure I have that correct.
All right, I see your screen. Basically, you're obviously it's not going to be in that form.
Yeah. it's
There
good.
we go. That's the last one, right? Oh, nice. They look good.
Yeah, let's take it. Let me look at the,
Can I make sure that I can do one thing? 1 second.
Go ahead.
I always have a little hard time doing this.
It's all right. We have time. We have a half hour.
So let's minimize that. Save again.
Yeah, we can run for.
you look like a movie actor on your
He
on your
does.
LinkedIn account, and you look, yeah, you look great.
Thank you. So, okay, I'm screen sharing.
Yes.
I want to do presenter view and then
Yeah,
make
yeah.
show
Okay.
that right.
So go to view and on over to the right, click on that. You're gonna see, that's not the one. Go to slideshow. My mistake. Go to slideshow. And now you're gonna see present online. Let's see if that works. No, that's not the one. Don't do that. Oh, here, use presenter view. You're there. See on the
Yeah,
right
that's
there?
it. Mhm.
Yeah, so you should be fine. Go ahead and click start go to slideshow and say from beginning to the all the way to the left. Click on that. And that looks great here. You'll be
Yeah, that
in the
looks
corner
great.
like that. And then they came
It
up.
doesn't show my presenter view though.
Would you want to show the
You
presenter?
don't want to
view?
show it that
You
way. You
don't
want to show
want
your
to.
full slide.
You want, right. You
Can I
want to
see it this? Can
Go
I
ahead.
see my presenter view?
Do you?
I'd like to see it myself.
You don't see it yourself is what you're saying, right?
Right.
Chris,
got-
can
We
you
got
help
one
me
or
with-
two monitors.
I just have the one. It seems like I've done it though. That'll be all right.
Look at monitor automatic. Let's see what that says there when you click on it.
Should be primary if there is a choice.
Okay.
This
So
will be
up
fine.
here, see this monitor thing above presenter view?
Monitor thing above presenter view.
All the way
To
to
your far right.
in the right hand side, right above this, yeah, there, that right there. Click on that arrow there.
Oh, I can't see it because it's in practice session, I guess is what it's doing.
Oh, so you don't see your on your PowerPoint, I mean. See it here?
Yeah, it lets me click on present. I click
It
on
does.
view.
That one there. What does it say when you click on that?
Yeah, go to
Primary. Click
primary.
on primary.
Okay.
All right, so try now to show it again. Do you see your presenter view now?
No, but it's okay.
Okay.
Can I just take a look at your, go through your slides real quick?
Yeah. Let me start again.
Okay, so if you wanna go all the way back again, I'm sorry. Go to your title slide. Okay, if you want to leave that up while I'm introducing, then you'll go to your next slide. You'll do your own disclosures. Okay, and then,
Do you feel the need for me to read these or can I just?
no, I
No,
mean,
you
I
don't
would
have
just
to,
say-
because there's no CEUs being earned. I'm sorry,
Yeah.
Chris, my
No,
bad.
that's okay. Yeah, no, that's okay. Yeah, just leave them up there and say, I have a few disclosures that I wanted to share with you. You can read them here. I mean, I think most importantly, when you say you're a consultant for Aspire product, here, people look for you to not oversell the IA adapter, right? Because you've invented it, you're a consultant, but the talk of today is really the utilization of IMST for OSA right? And then you speak about the IA adapter as something that now can be utilized with the well-known EMST 150 and EMST 75. And this gives sort of a single use, ability with the IA adapter now inside of the products that Aspire receives. But, people always have a sensitivity that we're overplugging, our devices for our own benefit. But this talk today is really about, the possibility of using inspiratory muscle strength training for obstructive sleep apnea. So we'll take it from the clinical side of it. I'll plug your development of the IA adapter.
And I won't refer to it otherwise, really.
Yeah.
It's not relevant. So,
Okay, do you want to run through them or?
Yeah, let's
Sure.
go to the next, let's do the next one. And you got 30 minutes, so you feel like you can get through all the content? Your slides are pretty content heavy.
I thought it was 45.
Yeah, I think I told him 45, Chris.
Okay. I would say we probably at about 30, you're starting to
Wind down for a question.
Yeah, well, people, 45 is long. So if you can hit it somewhere between 35, somewhere in there, and we can, let's give enough time to give them Q&A, but 45 just listening will get long for people at this time of night.
Okay, well, I'll try to move them through them quickly. I think the toughest thing though is that, there's not a lot of content knowledge for the audience. So some background is probably necessary, but
Yeah, no, I don't disagree with you, but if we're getting right at 45 minutes, I want to have enough time to ask you questions, let them chat, because they really enjoy that ability to hear from you more informally as the expert, and we can bat it back and forth like in that.
Yeah, they really love when Dr. Sapienza and whoever the speaker might be kind of banter and talk and present she presents you with some questions that they give, and you guys can talk about it too. It's very natural at the end. It's kind of like a podcast. You're right.
Mhm.
So, and that'll be that. It's pretty natural. So,
Okay, let's go to the next one.
both these first two slides, they can be gone over pretty quickly. I mean,
yeah.
just hit some highlights here.
And do we have a didgeridoo to demonstrate?
Do
Sorry. I'm kidding. It was a joke.
Do not.
Sorry.
All right, next one.
There it is. That's actually, that is actually a study. Oops.
Yeah.
Yeah, and some people won't even know what that is, so you'll have to explain that to them.
Nice.
Okay.
That makes sense, huh?
Mhm.
Okay, let's keep it going.
A lot of people too, this
Nice.
one, that's good. A lot of people have been asking about lung transplant cases.
Hey,
as
Harrison,
well.
that's what you do, isn't it?
We certainly do a lot of it. Yeah.
Are you using IMST as any type of prophylactic, prior to the lung transplant surgery?
We do.
If you don't mind me ranging that way with you, that was a big question that's been coming up at some of our latest seminars.
Yeah. I mean, so those would be part of their, we would just call it their, the dysphagia, preoperative dysphagia therapy program. I don't know if the inspiratory training is really targeting their dysphagia so much, but, definitely part of the program. They start with us.
What about, do you think, well, anyway, I might ask you something like, what, how do you think that helps their recovery if you do, not so much on dysphagia, but just on general inspiratory breath pressure?
Sure, absolutely.
Yeah, so the only thing I would say is they're kind of heavy text slide, and just kind of go through them in the Harrison way, just giving them good explanation, not going through every one point by point, but just storytelling.
Sure.
You're good at that. You've explained enough to me that in layman's terms that I know you can storytell.
Yeah, it's good.
All right, good. And how many? Yep. So that's another one. So there's 3 so far.
There's 5 studies and then there's this meta-analysis.
Oh, nice. Okay.
This meta-analysis is pretty interesting.
On the ones that used expiratory muscle strength training, do you know which devices they were using?
So really, this meta-analysis here, they call the Poohan the didgeridoo expiratory training. So the didgeridoo and the EMST 150.
Okay, good. Okay, good.
And then the 3 studies that use inspiratory muscle training all used pressure threshold devices from Power Lung, I believe.
Yeah, so basically we know we know that pressure threshold devices, period, pressure threshold devices, period. So
Yes,
that's
Yeah.
you know not to say the breather anywhere in these talks, right?
Yes, ma'am.
Only kidding. Yes.
this one's a little hard to read. So this one's a little
Okay.
hard to read. What's the take home message here?
1 second.
Mm-hmm. I forgot. I had forgotten. Mm-hmm.
Yep.
I totally forgot about this. It's going to be, this is very nice. It'll be really nice.
Yeah.
I
We'll
think
make it.
people were asking for it.
Yep.
So, yep. And Harrison does know about it. I'm excited about this. I like his background.
Yeah, looks good.
I'm actually going to be at Duke on Wednesday. Rick has an appointment. So,
There he is.
a lady,
All right, so-
I'm sorry, I was going to tell you a girl who knows you. I think her name is Alice Hudson, maybe. She was at our event this weekend and she spoke very highly of you, Harrison.
Well, good. It's
Yeah.
always good.
Yep.
How
So-
are things? Let's go through these. So these are, you're gonna have a take home message there. Most
Yeah.
clinicians won't understand this.
So yeah, this is just the meta-analysis of all the apnea hypopnea index data from this meta-analysis. And overall, they're showing that AHI drops by 3.1 events an hour compared to baseline. But when they look at subgroups, expiratory exercises and inspiratory exercises, they found that the expiratory exercises decreased AHI by 8.4 events an hour overall.
Wow.
So in 2 studies using EMST, one with expiratory muscle training, one with the didgeridoo, one with the EMST 150, AHI decreased by 8.4 events an hour. And this is thought to be clinically meaningful as well, with an AHI of 5 representing that clinically meaningful index there.
Good. That's good.
Yeah. that's-
So, and then this is the same thing, the forest plot on the meta-analysis date for daytime sleepiness. And so here, what the authors found that there was no statistical significance across the studies, but when they looked at inspiratory training only, there was a decrease in the Epworth sleepiness score of 4.4 compared to baseline. The minimally clinical important difference is thought to be about between 2 to 3. So this is both a statistical change and potentially a clinically meaningful change in data.
And if I said to you, what do you think that's caused by? You think it's caused by improving oxygenation? I
don't know, some people have proposed that perhaps this is due to some sort of cardiovascular benefit. It's not really clear to me at all what the effects of the inspiratory muscle training might be on daytime sleepiness and sleep quality. I mean, I think we can hypothesize a little better for expiratory muscle training, activating this upper airway musculature implicated in the disease, but it's not as clear to me as what the mechanism might be for inspiratory muscle training.
Yeah, hopefully it's just improving lung inflation, cardiovascular blood flow, and hopefully O2 sats is what I would think, but I'd have to look at the studies. What did they measure to show? Did they measure anything mechanistically or just show that it related to the events?
I mean, the only real mechanistic work is the stuff from Barnish and Bailey, where they were looking at some blood plasma levels and blood pressure. And, they see that blood pressure, for instance, drops in response.
Okay, so when I ask you, that's a good one. So when I ask you a question like that, that's a great response.
So maybe some sort of cardiovascular benefit.
Yeah, okay, good.
So, and then we have the forest plot for PSQI. So this is sleep quality. Again, no statistical significance across studies, but when they looked at subgroup analysis, inspiratory versus expiratory, they do see that the inspiratory training was associated with a positive benefit here. A decline of about 3.91 in the PSQI. That may not be clinically meaningful. That the value for that's been estimated to be about 4.4. But we do have statistical significance for inspiratory training for sleep quality, and it's approaching at least that minimal clinically important difference.
And when you jump back into these slides, which are great, would you just remind the people what the acronyms stand for? Because you'll have gone by them a little bit, probably quicker on the upfront. Say, okay, again, folks, PSQI relates to, because we find that some of the folks that come into these are really entry level.
Yeah, there's a lot of, I would say majority of everyone who attends are out of the 227, I'd say 150 are going to be entry level.
Yeah.
And I wouldn't really expect most speech pathologists to be super, familiar with.
Right, you're going to have to help them along. Yeah.
Yep.
But you might have we're starting to get some RT following now. We're starting to get some exercise physiology following, so we won't know who's on. And you may have a few people, there's been a little bit when Gail was doing some social media that was like, you people don't know what you're doing, studying sleep apnea. So, you may have a naysayer or two, but actually physiologically and mechanistically, it makes a lot of sense. I remember Harrison, when Paul Davenport wrote the first grant on this with OSA, and they were doing work with some researchers out in California EMST is pretty straightforward. It's adding a positive expiratory pressure to the airway to help entrain the airway. But inspiratory is interesting too, because what you're doing is you're creating that negative pressure in the oral cavity. So in some ways you're entraining the response of the muscles to keep themselves more patent as you're developing this inspiratory pressure. So the muscles are actually acting as a reaction to prevent the airway from collapsing. So it may be in training the muscles to keep themselves more patent when they're faced with a negative pressure inside the oral pharyngeal cavity.
That's a good concept. So I got a couple more slides here. This is about speech pathologists and OSA. So, overall speech pathologists don't know a ton about OSA, but they do see a lot of the patients on their caseload.
Yeah. That's a good point. So yeah, let's run.
I would say instead of saying they don't know a ton, you could say, I realize, in my work through Duke, we see a lot of patients with OSA. You may too. Why is this information relevant to you as a speech pathologist? OSA is a debilitating condition. It's right up there as a high comorbidity, right? As you know, right? And they need to understand the relationship between OSA patients and their generalized, daytime fatigue. The fact that they may not be participating in tasks, the mental status of OSA, it's debilitating as well as to the family.
Cardiovascular risk increases.
The other thing too is, remember that Kate Hutchinson study that showed on the high resolution manometry that the pharyngeal wall compliance was improved with EMST, and that you were able to get more pharyngeal dilation with EMST. So another mechanism for enhancing pharyngeal muscle activity. So you get, again, 2 for 1, right? You're working on the swallow while you're working on the patency of the pharyngeal space.
Right.
And if you're going to choose something, if this is going to work, the hypothesis is if this work continues, the individual may not just have to be presented with passive positive expiratory pressure throughout the night. If this works to train them and we can slowly wean them off of CPAP, which I don't know, those are sort of, I always talk to them like, what are the studies in the future? What
Yeah,
this.
I mean, I think right now I would view this more as a treatment modality for people who are unwilling or unable to tolerate CPAP. The data are awfully convincing for CPAP. But regardless of that, I mean, that's a large percentage of patients, those unwilling or unable to tolerate CPAP.
Yeah, that's right. Or a lot of people, even if they're unwilling and unable, a lot of people that if given a choice, right? If they're a candidate, if given a choice, I would much rather be on an active treatment than be on a passive treatment that I have to be exposed to it to keep my airway open.
Yeah, I would just say we'd have to be careful about that, because practice guidelines are so strong in support of CPAP. I think anything besides CPAP, whether it be a mandibular advancement device or respiratory muscle training of some sort, or whatever it is, are really secondary treatments. And really, CPAP needs to not be a good option, I think, for most of those people if you really want to be in line with practice guidelines.
Guys, we're getting about 5:25. So if you want to get a drink or go to the bathroom or before we.
So
Okay,
Gail,
I do.
Remind us how we're going to see us go live. You want to go
Yeah,
back up?
I'm gonna click on start webinar.
Let's go back to the top of the slides. Harrison.
Yep. So we're gonna start here. That's gonna be on the screen. You're sharing your screen there. Chris, you don't need to share a screen right now. So that way you don't have to, I'll go back.
Yeah, I'm good.
When
You
I
don't see
click
anything
start
from-
webinar, my video is going to be off. I'm going to mute myself a minute before. I'm going to start the webinar, and then Chris will take it from there and introduce you, Harrison, and then you take it from there. And then towards the end, I'll give you, Chris will give you some kind of a hint that we're getting close to the end, or however, questions. You don't have to worry about questions because I think Chris will ask you throughout, and we'll be answering what we can.
Yeah,
in the chat.
should be fine.
So,
I'm not going to interrupt
don't
you.
So don't even worry about the questions until the end. And we'll read them to you, or you can see them at that point, and I'll cut and paste them to bring them to the top or whatever.
I'll manage the questions for you.
There you go. So she's going to moderate for you, so that way all you got to do is what you do best. Teach them. So,
Okay.
All right.
You mind if I step away for 2 minutes?
Yeah, no, go right ahead. You have about 4 minutes.
Okay, thank you.
Thank you, Harrison.
Oh, good.
Yeah. I mistakenly pressed you. What happened was when you were talking, my phone was recording, and you lost muscle activity, and I was like, what the that's why it says that. So
I get it.
yeah, so anyway, yeah, I did tell him 45 minutes. I don't think I separated question and answer.
Okay.
Whatever.
Okay.
So that was my fault.
I'd like to see these go 30 minutes, but you
Yeah.
know what? Actually, I take that back because we did want to go an hour. We were going to start to ask speakers for permission to record so we could offer these as post-op
Yeah.
PEUs.
So
But you're not recording this one?
I am recording. I record them all in case, and they will, we give a password to people who attended and want to go back to it or whatever. But I think what we're going to do from now on is it's only going to be up for like 5 days afterwards, and you have to have the password to see it. And we will.
And we should talk about when you come, how we get these listed for CEUs.
Yeah. Well, yeah, I'm going to send you an agenda beforehand, and you send, you add to it or whatever, subtract from it, whatever. And then, yeah, we can go through everything. So I had a discussion with John today. Not a very fun one, but mostly about how, we are behind on the education, and that's because we are so busy. We're doing our part. But we want to make sure that we get this done properly, but everybody and their mothers jumping into the education thing now. So,
Yes.
he keeps yelling and talking about education and we got to do this and we got to invest, but then I don't see him for 3 weeks. So,
Well,
you
if
know,
he's got to invest, you got to invest resources.
research, well, yeah, research, right, exactly. And that's financial and physical,
Right.
some
Right.
sweat, sweat equity there. And I'm not seeing any of it. So anyway,
Well, I'm happy to pre-meet with you too.
yeah, we'll get there. So anyway, looks like we're about what, 2 minutes out?
Yeah.
All right. Yep. So like I said, I'll let you know when I'm going to start. And then I'm going to be in the background. I'll be here listening and watching the chat so that if there's questions like, is this going to be recorded or can I have Harrison's slides? I can say absolutely not. The recording, it is going to be recorded, but no one's going to have access to it. Harrison's slides are Harrison's slides. If you want access, you need to talk to him. Can I give your email out? Oh, it's here. Okay. Yeah.
He's got it. Yeah.
Yep.
Yeah.
Okay. So, so it's your intellectual property. I'm not giving that away.
Yeah.
So they
Let's
know.
go.
All right, let's move. Ready?
Let's do it.
I am muting, stopping my video.
Well, good evening, everyone. Dr. Chris Sapienza here for another free event from Aspire Products. I am just so excited about today's lecture. We have with us Dr. Harrison Jones, and Harrison and I have known each other for a long time. Harrison was a graduate of the University of Florida, I think back in 2007 now, with his PhD from the University of Florida in Communication Sciences and Disorders, but has gone on to have just a stellar career at Duke. And today, this is really going to add to our knowledge base because the work that Harrison's been doing and exploring with inspiratory muscle strength training, and one of the inventors of the inspiratory IA adapter that is now a product sold by Aspire Products, was really due to the contributions of Dr. Jones's work. But today we're going to hear him talk about emerging evidence for the use of respiratory muscle strength training, both expiratory and inspiratory, with patients that have obstructive sleep apnea. So it is my pleasure to introduce to you our expert, Dr. Harrison Jones. Thank you.
Thank you. Yeah, so it's a pleasure to be here. These are my disclosures. And I'm here today to talk about obstructive sleep apnea, OSA. OSA is a common sleep breathing disorder, really resulting from repeated episodes of upper airway narrowing or closing during sleep. And this is a really big problem throughout the world. There's a worldwide prevalence of about 1 billion people. The upper airway collapse happens at levels like the velum, oropharynx, base of tongue, epiglottis. So these are structures well familiar to the speech pathologist. I think the other critical thing I want to say here is that OSA is diagnosed with either inpatient or home sleep studies. And the primary outcomes from these include the apnea-hypopnea index. So the number of these airway closure or narrowing events that occur per hour. So mild OSA is going to be 5 to 15 events, moderate 15 to 30, severe 30 or more. When we think about treatment of OSA, without a doubt, CPAP therapy, continuous positive airway pressure, is the gold standard treatment, which is generally very effective in reducing AHI. The biggest problem here is that adherence and tolerance is often suboptimal. So patients wear a mask. It provides a positive pressure into the upper airway and splints it open during sleep, which generally has a very pronounced effect on these apnea, hypopnea events. Nevertheless, adherence and tolerance is often poor. There's a variety of other treatments that are really second-line treatments, whether they be mandibular advancement devices, surgical treatments, aerobic exercise, weight loss, and really what we're going to be talking about today, which will be respiratory muscle training, which is a little bit related to what is called in the literature oropharyngeal exercise or myofunctional therapy as well. But we're going to really focus through the lens of respiratory muscle training. So this was really the first study that was published on this topic. And so in this study, the authors examined the impact of didgeridoo playing. So this is a wind instrument, that involves circular breathing. It's a little complex to play, is my understanding, but they had lessons, and they looked to see the effect on daytime sleepiness and other outcomes related to sleep. So daytime sleepiness, AHI, and sleep quality, those are the big things that we look for in terms of changes, in terms of positive changes that might occur with therapy for patients with OSA. In this study, they had 25 patients with moderate OSA who completed 4 months of treatment of this daily didgeridoo playing for at least 20 minutes a day, 5 times a week. Their outcomes included the apnea-hypopnea index, measures the daytime sleepiness, which was calculated with the Epworth sleepiness score, and sleep quality. This is the Pittsburgh Sleep Quality Index. And so in this study, they found that compared to the controls, the treatment group had significant improvement in their AHI, as well as daytime sleepiness and partner rating of sleep disturbance. It didn't have any effects on sleep quality, but there was definitely improvements in AHI and daytime sleepiness. And they suggested that regular didgeridoo playing is an effective treatment alternative that's well accepted by patients with moderate OSA. And so that study, I think we can conceptualize that prior study as more of an expiratory muscle type training study. This study here from Varnish and Bailey was an inspiratory muscle training here. And so they were looking at the effects of inspiratory muscle training on sleep and cardiovascular function in adults unable to use CPAP therapy. So they had 24 participants, half were randomized to the treatment, half the placebo. The treatment group did inspiratory muscle training at 75% of their maximum inspiratory pressure or their greatest inspiratory muscle strength. And they did 30 repetitions 7 times a week for 6 weeks. The control group performed low resistance inspiratory training. And their outcomes again included AHI, sleep quality with the PSQI, as well as blood pressure. And they found that the subjects performing IMT had statistically significant improvements in their nighttime arousals and sleep quality, as well as reductions in both systolic and diastolic blood pressures. There was no effect on AHI in this study, but they did say that they concluded that IMT improved sleep quality and blood pressure without an improvement in the apnea-hypopnea index. And they suggest that IMT offers a low-cost, non-pharmacologic means of improving sleep and blood pressure in patients who are intolerant of CPAP. Okay, so moving forward, this study from Kuo et al. 2017, this was looking at a relatively short duration expiratory muscle strength training regimen. So they trained for 5 weeks using the EMST 150 at about 75% of their maximum. They performed 5 sets of 5 repetitions 5 times a week for those 5 weeks. About half their participants were randomized to the treatment, and the other half were randomized to controls. In the control group, they trained at 0% resistance, is what the author stated. And they found that treatment had a marked effect on the AHI, so this decreased by about 40%. They also saw the maximum expiratory pressure increased and that sleep quality improved. And they found that the changes in AHI and the maximum expiratory pressure were negatively correlated. So as maximum expiratory pressure increased, AHI decreased, and they proposed that EMST effectively improves sleep apnea, sleep quality, and expiratory muscle strength in OSA participants. They also found that those with moderate OSA had a greater impact than those with mild OSA. And this is another inspiratory muscle training. So this is using a pressure threshold device. They're examining the effectiveness of IMT on sleep and functional capacity to exercise in OSA subjects. They had 16 subjects, 8 randomized to treatment, 8 to the control. The treatment group performed 3 sets of 30 IMT repetitions at 50 to 60% of their MIP, 2 times a day, 7 times a week for 12 weeks. So a good bit more repetitions were performed here. And the control group performed low resistance training. And they found that sleep quality significantly improved in the treatment group relative to the control group. There were no changes in spirometry measures like FVC, forced vital capacity, maximum inspiratory pressure, maximum expiratory pressure, cardiopulmonary exercise testing or daytime sleepiness. But they did find, again, that 12 weeks of moderate load IMT resulted in improved sleep quality without impact on functional capacity to exercise or excessive daytime sleepiness. And then this is another study examining threshold inspiratory muscle training on OSA. These were 22 patients here with moderate to severe OSA, randomized to what the authors called TIMT, threshold inspiratory muscle training, 16 participants, and then 6 participants in the control group. The resistance was at 30% for 30 to 45 minutes of training 5 times a week for 12 weeks, as well as diaphragm breathing exercises. The control group just had routine clinical care. They saw in this study non-significant improvement in AHI, so the apnea-hypopnea index in treatment versus controls, though significant improvements in ESS, which is a measure again of daytime sleepiness, in the treatment versus controls. So in the treatment, it actually improved, and in the controls, it worsened. They looked at responders versus non-responders and did see that in the responders, AHI did improve, and that those with lower AHI tended to respond better than those with more severe AHI scores. So they conclude that OSA severity and daytime sleepiness were significantly attenuated, and that home-based TIMT training is simple, efficacious, and cost-effective. And so I think this is perhaps the best summary of these studies to date. So this is a meta-analysis from a Brazilian group, and they're really looking at what are the effects of respiratory training devices on obstructive sleep apnea outcomes in adults. And so they looked at studies that met these criteria. These were adults with mild to moderate OSA. The intervention included respiratory training devices like pressure threshold devices, or in the one case of the didgeridoo. They were compared to no breathing exercises. Outcomes included the apnea-hypopnea index, or AHI, daytime sleepiness based on the ESS, and sleep quality based on the PSQI. So these are really well-validated tools in the sleep disorder literature. And they had 3 studies that used inspiratory muscle training, which we've reviewed today. They had 2 studies which used expiratory muscle training, again, which we reviewed today. The expiratory muscle training, they also put the didgeridoo study in that group. These training regimens were performed 5 to 6 times a week for 5 to 16 weeks. And they were generally found to have low risk of bias, except for the didgeridoo study from Puhan et al., which had some limitations due to alocasia, concealment, and blinding issues. So this slide's a little bit much to look at here, but these are powerful data. Across all studies, they found AHI, so the number of apnea-hypopnea events that occur per hour, compared to the baseline, decreased by about 3.1 across these studies. But they did a subgroup analysis, and they looked at both expiratory exercises and inspiratory exercises separately. And they found that for the expiratory exercises, AHI decreased by 8.4 events an hour compared to baseline. Considering that the minimal clinically important difference for AHI is estimated to be about 5 events an hour, a difference of 8.4, a change of 8.4 events an hour is clinically meaningful. So in summary, in 2 studies using expiratory muscle training, one with the didgeridoo, one with the EMST 50, for 16 weeks and 5 weeks, AHI decreased by, again, 8.4 events an hour, which appears to be clinically meaningful. This is from the same meta-analysis study here. So again, when they look across all the studies, they're looking at daytime sleepiness here with the Epworth Sleepiness Scale. There was no statistical significance across all these studies. When they did a subgroup analysis, so looking at inspiratory training, they found that there was a decrease in these ESS scores of 4.4 compared to baseline. And also, we know the minimal clinically important difference in ESS lies between 2 and 3. So this change of 4.4 appears to be clinically meaningful. So in summary, in 3 studies using inspiratory muscle training with pressure threshold devices, 5 to 7 times a week for 6 to 12 weeks, ESS improved by 4.4, And this value was both statistically significant and appeared to be clinically meaningful as well. And finally, the last of the slides like this is about sleep quality. So the Pittsburgh Sleep Quality Index, again, this is a really well-validated measure in this literature. And again, similar to the ESS results, we don't see statistical significance across the studies. But when they do a subgroup analysis, looking at both inspiratory and expiratory training, they find significant improvements in sleep quality in both the inspiratory training group and the expiratory training group. This effect size was larger, though, for the inspiratory exercises, and it was maintained even after sensitivity analysis, whereas that disappeared for the expiratory training. So we saw that the PSQI improved by 3.91 due to the inspiratory training in these studies. The minimal clinically important difference in PSQI score is thought to be about 4.4. So this change of 3.9 maybe just under that clinically meaningful threshold, but it's certainly approaching it. In summary, in 3 studies using inspiratory muscle training, using pressure threshold devices, 5 to 7 times a week for 6 to 12 weeks, the sleep quality improved based on the PSQI. And it was statistically significant and approached the clinical significant value. So I guess the summary here is that the results of this meta-analysis suggest that breathing exercises lead to a measurable improvement in AHI for patients with mild to moderate OSA, as well as an improvement in sleep quality and daytime sleepiness. So I think one point that always comes up when I talk to colleagues about this, many of whom are speech pathologists, is, what does OSA have to do with speech pathology? And I mean, we're finding out more and more relationships between OSA and swallowing disorders at the very least. Swallowing and upper airway patency during sleep has shared anatomical and neural control mechanisms. And we're finding that the prevalence of dysphagia in patients with OSA is surprisingly high. So ranges between 16% to 78% of OSA patients across 17 studies. 65% of these studies reported pharyngeal swallowing impairments in OSA patients, including pharyngeal swallow delays and penetration or aspiration. So, there does seem to be a relationship between swallowing problems and OSA. There's also some data about SLP's knowledge, attitudes, and practice patterns regarding OSA. Compared to physicians and dentists, based on a standard questionnaire, the topic knowledge among SLPs was a little bit lower than physicians and dentists, which isn't surprising considering our training. But over 50% of the SLPs reported OSA patients were on their caseload, the majority of whom were referred for dysphagia. And these authors also mentioned the fact that studies on the use of myofunctional therapy, what I would kind of call oral pharyngeal exercise or upper airway muscle training, which uses speech and swallowing exercises to reduce the severity of OSA, have shown consistent improvements in OSA severity. So few SLPs in this study reported providing this sort of treatment, but as the authors note, enhancing education among SLPs may alter their perception of their role in OSA management and may facilitate translation of this therapy for OSA into the clinical setting in collaboration with the sleep physician team. I'd like to briefly mention the scope of practice. Is working in OSA as a speech pathologist a violation of the scope of practice? My interpretation would say no. We know, based on the scope of practice, that the practice of speech language pathology continually evolves. And, we have a big historical precedence with this, with our work in dysphagia, which was long in development, really before it became such a standard part of practice. The Code of Ethics specifies that professionals may only practice in areas which they are competent based on their education, training, and experience. And each individual must evaluate his or her own experiences based on education, their practice, mentorship and supervision, and ongoing professional development. And these experiences define the scope of competence for each practitioner. And each SLP should only engage in those aspects of the profession that are within her or his professional competence. So I think depending on your background, training and knowledge, there's certainly some crossover with speech pathology populations, like patients with dysphagia, as well as some support that this may not be outside of scope of practice. You know, a quick slide here. From a guideline study here, and they asked the question, in adult patients with OSA, should myofunctional therapy or no treatment be used? So again, myofunctional therapy for our purposes today, I think really we can think of just oropharyngeal exercise. And they use 6 RCTs to answer this question, including the didgeridoo study from Puhan and colleagues. And they, you know, these task force recommendations are always very serious and severe in many respects. And they don't suggest myofunctional therapy, which I would say respiratory muscle training is likely a type of myofunctional therapy or a type of oropharyngeal exercise for a standard or regular treatment of OSA, but for specific cases seeking alternative treatments for those who are reluctant to undertake surgical or mechanical strategies. So in many ways, I find this a surprisingly supportive recommendation from a task force like this. And they also say that for many patients seeking alternative treatment options, it may be an acceptable option. You know, regular follow-up should be performed. They also note the lack of trained professionals, and they specifically mention speech pathologists and concern regarding adequate training in this area for that group of clinicians. So, you know, I think they do provide some gentle support for the idea that myofunctional therapy, again, I would consider respiratory muscle training perhaps as a type of oropharyngeal exercise, so therefore a type of myofunctional exercise. They provide some gentle support for this concept, generally in patients who are you know, not able to, unable or unwilling to use CPAP therapy, the gold standard. And they also indicate that this is an important area for speech pathology and ongoing continuing education efforts in speech pathology. And I'd like to conclude today with really talking about my own experiences, my own clinical experience with treating OSA. So I've been doing this work here at Duke clinically for about 5 years. Patients with OSA are referred by 2 main practices, the sleep medicine providers in pulmonary medicine and pain medicine clinic, which is really a dentist who treats orofacial pain and constructs mandibular advancement devices. These patients, we've agreed that they're going to be referred for speech and swallowing assessments to assess, with a request to assess candidacy for oropharyngeal exercise for treatment of OSA. In my experience, based on the data, the best candidates would be patients with mild to moderate OSA, those who are unwilling or unable to tolerate CPAP therapy, the gold standard. Those are highly motivated for improvement. Those that are interested in exercise in general seem to be more responsive, more interested in this approach. And those who are exploring second-line treatments, such as mandibular advancement devices, weight loss, aerobic training, oropharyngeal exercise, respiratory muscle training, because those things often together can begin to approach the benefit of CPAP. Standard outcomes that I use in my clinic and we've talked about today include measures of sleep quality with the PSQI and daytime sleepiness with the ESS. And I usually link my long-term goals to these outcomes. It's much more difficult to detect benefit in non-symptomatic patients, those who somehow have been discovered to have OSA, but they don't feel a lot of impact from it. So they don't have daytime sleepiness. They don't have poor sleep quality. They're much more challenging. And in those patients, it's really hard to detect benefit. It may be that a repeat sleep study is required at some point. Typically, I recommend speech therapy for oropharyngeal exercise up to 2 times a month for 6 months. Just to be clear, when we put these requests into insurance, we've been always very clear that this is an unusual, in many ways, application of speech therapy. And so I'm not trying to pretend that we're working on their speech. We are being very upfront about the nature of the work we're doing here. I don't think any requests for insurance approval have been denied to date, which I've been surprised about. We haven't even been requested to provide additional information. And we currently typically provide oral pharyngeal exercise in the forms of respiratory muscle training, including both inspiratory and expiratory muscle training, for about 5 sets of 5 repetitions of both inspiratory and expiratory muscle training, 5 times a week at 50 to 75% of their maximum inspiratory and expiratory pressure, and provide progressive resistance over the course of treatment. At follow-up visits, I typically assess changes in their respiratory pressures, provide progressive resistance. So as their strength increases, turn the devices up a little bit to provide more resistance. Certainly perform troubleshooting and problem solving, and always ongoing try to assess the benefit of this to their OSA. I think really one thing I've learned is being part of a multidisciplinary sleep disorders team would really be optimal, which is not the case right now. There's some powerful data about the benefits of aerobic training, for instance, some powerful data about the potential benefits of respiratory muscle training. I think putting these things together, along with maybe weight loss, could really begin to develop some powerful alternative treatments for OSA that are alternative to CPAP. So, in conclusion, OSA is a common sleep breathing disorder. We have repeated episodes of upper airway collapse or narrowing throughout the night. This might happen hundreds of times over the course of an evening. OSA patients are frequently encountered on SLP caseloads, and there's emerging data that suggests respiratory muscle training, which I would propose provides a type of oral pharyngeal exercise, may have a role in the multidisciplinary treatment of OSA. Expiratory muscle training appears to improve AHI, the apnea-hypopnea index, while inspiratory training appears to improve daytime sleepiness and sleep quality. I would also note that SLPs are increasingly skilled and experienced in the clinical application of respiratory muscle training in many patient populations, like our work with expiratory training in dysphagia, inspiratory training in ventilator-dependent patients, for example. And again, if we think about inspiratory or expiratory muscle training being a type of oral pharyngeal exercise, I think this further supports the involvement of the speech-language pathologist. And finally, I think guidance from ASHA in terms of the code of ethics support this. We know practice patterns are constantly evolving, and that we have to consider our education, practice, mentorship, and supervision, as well as our ongoing professional development to define our own scope of practice and engage in those aspects of the profession that are within our professional competence. So with that, I'd like to conclude the talk. Feel free to invite any questions from the audience, and also my email's on the screen if anybody wants to ever reach out to discuss these things further in the future.
Well, thanks, Dr. Jones. And of course, there are some comments and questions coming in, and I have some of my own that may help kick off a little bit of an interaction between us and hopefully be beneficial for our listeners. The comment about respiratory muscle strength training is an oral pharyngeal exercise. I think there's a few people listening that say, is it really? Can you put that into a context about what we know mechanistically the EMST device and or the IMST device have shown with regard to this sort of concomitant of interaction synergy between what happens when somebody's training on an IMST or an EMST device? I think that's why you're moving it towards an oral pharyngeal exerciser based on these other studies that have shown this interaction with those upper structures.
Yeah, so I think we have a lot of data supporting the idea of respiratory training, activating pharyngeal, laryngeal musculature. And I think that's really the concept at work here is that, again, whether we're blowing against resistance or inspiring against resistance, there's many mechanisms that could be at play here where we're training the upper airway, we're training the velopharynx, training the base of tongue, training laryngeal musculature, which very well could be implicated in OSA. Probably not as much really an oral exercise exactly, but the tongue is an oral structure, and I think it's hard to separate those things out. So, I do think that respiratory muscle training with pressure threshold devices is very reasonable to think about it as a type of oropharyngeal exercise.
I mean, I have to agree with you because I think that what the literature is showing now, and it's emerging. I mean, it really is. I mean, I always say these studies sort of started out early in the early 90s, and the data now coming out on respiratory muscle strength training is logarithmic. There's, probably at least I would say a good 70 to 80 papers published a year in different journals, not only speech pathology. But what we're finding, right, Dr. Jones, is that you can see that the orbicularis oris muscle is being trained when you're on these trainers. There's evidence of that. The buccinator muscle is engaged when you're utilizing EMST. There's been some evidence that you get some increased activation of the dorsum of the tongue. You have information on EMST now where we're getting more pharyngeal dilation. You already commented the levator veli palatini, is activated during EMST, raising up the velopharyngeal port. The vocal folds adduct with EMST, they abduct with IMST. So I think what you're alluding to here, and just for the audience sake, is that we are implicating, Harrison is systematically showing you the data that's emerging now on could these devices that are not passive entities, they're active entities of training, be influential on metrics associated with OSA. And whether that's complementary to CPAP, whether someday we may find a CPAP versus, an IMST or EMS treatment, I think is what the future holds. Folks also, always ask, and I know you've been asked this question 1,000 times, but I want to talk about it here because a lot of people with OSA also have COPD. And so could you speak a little bit from your clinical experience as well as your research experience, how those two might interact, and if there's any cautions that you would see going forward with that, that symptom that's associated with OSA, the COPD?
Yeah, I mean, COPD would be one of the patient populations where we have much more data than in other patient populations on the role of inspiratory training to increase breathlessness, for instance. So, however we define dyspnea or breathlessness, I mean, there are a lot of data supporting the role of inspiratory muscle training in patients with COPD and other kinds of breathing disorders. For the most part, I mean, I also get a lot of questions about, should I think about inspiratory training or expiratory training here? I think that if we're really thinking a little bit more about a breathing problem, then I think for the most part, drastically simplifying things, I think inspiratory training probably makes a little bit more sense than expiratory training if we have to choose. Although I think these things are best done in concert with one another for the most part. But I wouldn't think of COPD being a contraindication at all for inspiratory training, and perhaps really more accurately an indication for inspiratory training.
Right. I agree wholeheartedly. It's often a question. And I think the reason, in terms of leaning towards IMST, I mean, you showed two really good sets of data. But as we were talking about earlier, IMST folks, when people are producing a high negative pressure by utilizing the IMST device, that negative pressure is occurring in all parts of the supraglottic, glottic and lower airway. So what has to happen is the patient has to adapt to preventing that airway from collapsing when that negative pressure is being produced. So people have thought of IMST as a technique for reducing OSA symptoms because, in fact, you're entraining the muscular system to create a posture whereby the airway doesn't collapse upon itself. The last thing the human body wants is for the airway to collapse. So you can actually use IMST as a way to entrain the physiology to compensate for that high negative pressure. So that's some of the mechanisms on IMST. And Harrison, maybe you want to comment a little bit on some of the mechanisms associated with EMST as a treatment.
Yeah, I mean, thinking that through, I mean, perhaps, we're seeing with expiratory training, we're seeing these structures sort of more actively exercise in the way we typically think about exercise. You know, they're moving through a larger range of motion against this resistance, and then perhaps again with inspiratory training, it's a little bit more of a so instead of like an isokinetic type repetition, it's more like an isometric repetition where we're having to sustain a posture,
That's right.
suggesting to resist this negative inspiratory force.
Correct.
They could be very complementary ways to target this upper airway musculature.
Right. So and thank you. And one of the comments from Christina was she finds it hard enough to just even do a little therapy with patients with OSA. She's kind of hard to imagine, how do you combine the two together? And is that what you're recommending, or are you recommending one over the other? I mean, I know the literature is just emerging. It's a hard call.
Yeah. So, and there are really no data that use pressure threshold training combining inspiratory and expiratory training. So these, we've got data suggesting expiratory training improves AHI, inspiratory training seems to improve sleep quality and daytime sleepiness. I think for the patients I've worked with this, I have not found that combining them together is a tough sell at all. These are, again, usually very high. If they get to me, they're very highly motivated participants, often really committed to behavioral treatments in general throughout their life. So these are people that respond positively to exercise. They're actively trying to resist, for whatever reason, due to not accepting CPAP or not being able to tolerate it. Some people get nasal sinus infections and things like that. So they're in many cases desperately seeking alternatives to sort of traditional medical therapies. And I haven't found this to be a tough sell at all. I think that the patient burden to complete 25 inspiratory and 25 expiratory repetitions 5 times a week is very, very modest. And I think we're talking about something on the, of like 10 to 15 minutes of time probably. So I haven't found that to be the case. If I had to choose, I guess, I might even make a different thought process on that now and think about, am I really trying to improve their AHI, or am I really trying to improve their sleep quality and daytime sleepiness? So
remind us of that. That's it. You make a good point. Remind us, go back to that data that you showed. If I were to make a choice, put that in a nice clinical summary for you. If I were to make a choice based on those metrics.
Yeah, and I think hopefully with more data, this picture would begin to really clarify, because
it will. Yeah.
AHI, sleepiness, sleep quality to be so separate of events, but these data so far have been showing that the expiratory training really appears to improve the AHI, reduce this upper airway collapse. And, by whatever mechanism, the inspiratory training appears to improve daytime sleepiness and sleep quality. I mean, there's been hypothesized, there's known cardiovascular benefit of inspiratory muscle training. Perhaps that's playing a role there. So it's hard for me to not think about AHI being really at the forefront of OSA. I mean, that's how we diagnose and define it and conceptualize really everything around it. But perhaps if I had a patient who was really suffering from daytime sleepiness and poor sleep quality, at the same time was very reluctant to participate in, a program like this and would only give 5 minutes a day, maybe for that patient, inspiratory muscle training would make a little bit more sense. But
no, I think that makes good sense. And if I think about it, Harrison, 10 years ago, we knew very little about EMST and swallowing. We knew very little about respiratory muscle strength training's impact on voluntary cough and reflexive cough. So I think today, what you're highlighting is it is emerging. You're providing the audience with just the beginnings of utilizing these devices with OSA. And this tends to go very rapidly in the field, right? It's Harrison has the position where he works as a speech pathology, but he's also working in a head and neck surgery department with ENTs. You're going to find this literature coming out from respiratory therapists, respiratory physiologists, pulmonologists, otolaryngologists, speech pathologists. So we have to attend to the literature coming from all those journals. So I would expect in another 6 months to a year time, you and I are going to even have a further discussion of what this data is showing. But I was curious on your work with your ENT colleagues. You always said you don't have much pushback. What does the ENT community that you're working with feel about the utilization of these devices? Do they know about them? Do they understand when you go to the ENT conferences how they can be implicated in sort of these upper airway exercises? Because sometimes the clinicians just have to be able to sell it to the people they're working with.
So I have to be careful here, but I work with a lot of different professionals within medicine and surgical departments. And I would say that the ENT doctors are maybe a little less receptive to this stuff than many other groups I work with. So the pulmonologists, the critical care medicine doctors, we do not need to sell them on inspiratory muscle training, expiratory muscle training. They're on board. They clearly understand the impact of weak inspiratory musculature on their patients who are failing to wean from the ventilator. I'll have
to, and I don't want to that you work for them, but you can say that I said to them they should read the old work of Sam Kuna and Gail Woodson, who showed that synergistic effect of respiratory events on vocal fold movement. It was really clear that, when you take an inspiration, the vocal folds abduct, and when you take a hard expiration, the vocal folds adduct. So there really is a clear implication between respiratory muscle strength training and laryngeal positioning. But I want to ask you another question, because the questions are coming in. You mentioned cardiovascular, and I've seen some studies where EMST is helping to mitigate high systolic pressure. Could you comment a little further on what your thoughts are on the cardiovascular side associated with inspiratory muscle strength training?
I mean, this might just be a form of cardiovascular aerobic type exercise. We data from Varnish and Bailey that I reviewed today in OSA patients. OSA patients has shown both systolic and diastolic blood pressure dropping in response to inspiratory training. They've also seen similar phenomena in patients without high blood pressure. So there's no doubt. I mean, there are some strong data in support of the cardiovascular benefit of inspiratory training. And I think it makes a lot of sense to think about that as sort of a cardio aerobic type of exercise, perhaps for those patients.
And one of the questions came in about how do you go about measuring an inspiratory peak flow rate? A lot of people measure expiratory peak flow rates, and they use the standard, micrometer peak flow rate or the analog ones that are out there. But you can measure peak inspiratory flow rate. There's some other devices out there that you can look at. So we don't confuse people. Pressure threshold devices are pressure dependent. You have to generate a certain CmH2O to open up the valve. But if you're interested in measuring inspiratory peak flow rate, you need to look for whether you use something that's connected to a spirometer. There's inspiratory peak flow meters called InCheck. So just do a quick Google search and you'll be able to find an inspiratory peak flow meter, just like you can an expiratory peak flow meter. There's a question, I'm not sure if you've heard of this. It says, what is your opinion of the Inspire sleep apnea product?
Yeah, so I believe that is referring to hypoglossal nerve stimulation for OSA. There's definitely been a lot of interest in that among otolaryngologists. I would say it's awfully preliminary. And I would have to look closer at their data. I mean, I haven't evaluated that data like I've evaluated these data, so I don't want to overspeak. But for the most part, I would say that those large organizations that, are recommending practice guidelines, they have not been super supportive of that. I believe that most patients who receive that need to have a DISE, a drug-induced sleep endoscopy, to assess their exact patterns of collapse, and that this is thought to work for certain patterns of collapse and not other patterns of collapse. I think it is a difficult thing for insurance coverage, is my understanding, but it's definitely something that's emerging. And
let's be clear too, Harrison, it's an invasive device. So what you're talking about in this particular talk is non-invasive exercise-based training, and the Inspire Sleep apnea innovation is invasive. I mean, it is a device placed inside the body.
Absolutely. And I'll never cease to be amazed by patients who say something like, isn't there a pill or a surgery I could take?
Right.
Especially when it's a surgery. But I think there's a lot of interest in the Inspire device. I think that the prior surgeries that have completed for OSA, often by otolaryngologists, do not hold up very well. And they seem to have modest benefit that doesn't persist over time. There is a lot of interest now all of a sudden for this new approach, but I think the jury's still out on that.
Yeah, thank you for that. I appreciate your feedback on that and intellectual contribution. Could you go back through, I didn't see age ranges on the studies. Is this, when you look at this implementation or these meta-analyses, was it more female? OSA tends to be more male. Did you notice any slant on the age ranges or gender of these individuals?
Well, I mean, OSA is certainly more common in men. These studies were all studies in adults, although there is a little bit of pediatric literature as well. I don't know if it's respiratory muscle training specific. I think it's probably more in the oropharyngeal myofunctional therapy type literature. But these studies were adults, 18 and up for the most part, mild to moderate OSA. And I'm sure there was a relatively greater number of men versus women. And that's just kind of, I mean, male sex is one of the
Right.
risk factors for OSA.
Right.
Other things include, the size of the neck, which also may be related to male sex. Those are a couple really big ones right there.
Good.
There's a Stop Bang questionnaire, which is a screening tool for screening for OSA. And, one of the ways you can get points on that towards, having a high risk for OSA is just by being male, as well as neck size.
The day-to-day, if you would, you're a clinician. Are we hanging a shingle out to say we're here to treat OSA? Are we treating OSA as a comorbidity along with dysphagia and what you're seeing come into your ENT practice? And give us a little bit, because there's the protocols different so much by weeks and MIPS and MEPS and percentage. Can you offer a little bit more of an idea of how you standardize this when you work with this group, or if clinicians were working with this group?
Well, I think some things to keep in mind is, those measures like the PSQI, the ESSS, those are really important. They're going to be really important. If we're going to try to implement this clinically, those are going to be vital as a long-term goal, as an outcome measure. And that's going to require a little bit of foresight on a clinician's part, because, we're not used to doing the PSQI. We're going to need to know, understand how they got there, why they're not using CPAP, why CPAP is not an option for them.
Right.
Sort of get into their head about this. I don't think that sleep physicians should be referring this as a frontline therapy. And I don't think their professional organizations would support that at all.
Good. Good. I agree.
Nothing besides CPAP is a first line therapy. So mandibular advancement devices are much more well accepted in the community as a second tier treatment for OSA. But, that would be a real misservice to patients if you were telling them to just get a mandibular advancement device instead of the CPAP. I mean, that would not be consistent with these professional organizations.
And I like the way you're talking about, they're not a candidate for CPAP, and this is where our role, definitely could be expanded. Somebody else had asked a question about any studies that you might be aware of for treating upper airway resistance syndrome. Are you aware of any application? I mean, I can certainly think mechanistically of the application of that, but anything in your work?
Yeah, I'll be honest, nothing really rings a bell. I'm not really familiar with that condition. I guess I'd need to know a little bit more about it.
Well, I mean, it's anything that where a child might, whether it's enlarged adenoids or tonsils, or they've had some, surgery and that they're just left with a high upper airway resistance. I think in my opinion there, I would say to the clinicians, what is the symptoms that the patient is presenting? If it is a dyspnea because they're not able to bring in, a high inspiratory flow rate or create that inspiratory differential in order to get breath in, then you would want to go EMST. If the symptom is, they're having difficulty with vocal loudness or speech or anything along those lines, then you would want to go EMST. So whenever you have a resistance problem, whether it's in the upper airway or the glottal airway or the lower airway, think of the symptoms and then look mechanistically at what each of these pressure threshold devices do. So I think of EMST as really the device for, speech, voice, cough, and swallow. And I look at IMST as that device that's really shown a lot of great work in terms of breathlessness, lung expansion, prophylactically for, lung transplant patients, to Dr. Jones's point about cardiovascular health and aerobic exercise correlate. So
Failure to wean from the ventilator.
failure to wean from the ventilator, et cetera.
And I think we tend to think about expiratory training for the cough, but cough weakness could certainly be an inspiratory phenomenon too. So
Yeah.
if inspiratory muscle weakness is present in the setting of intact expiratory muscle strength, and there's a weak cough, then we might really want to think about inspiratory training. You got to load the apparatus to first in order to generate that propulsive force. So
yeah, whole other talk on whether we do combined modality or inspiratory, expiratory for cough. So, for folks tuning in, it's a whole other area of discussion. You had mentioned pediatrics. It said you may have seen a study with OSA and pediatric. Is that anything that you can actually reference? There was a question on that, on pediatrics and EMST and OSA.
now let me just move forward here real quick. Yeah, I want to stay in my lane here. And I don't have any clinical experience with pediatric patients with OSA. I certainly see pediatric patients, but I don't know enough about OSA in pediatric patients. But there was another meta-analysis that did include some oropharyngeal myofunctional type approaches, including some children. But I'd have to look at that closer. And like the scope of practice was saying, you gotta know your limits too. And I would feel like I really needed to do a lot of wood shedding in order to step in with a pediatric patient and make a meaningful contribution.
Yeah, I so respect that. And I think, in terms of looking at the literature, it's really scant in the pediatric population right now. So I don't think there's much additive that you could say to the analyses you've already presented. And I think people appreciate such a transparent and honest response. And the literature there, has to grow along with, what we've seen in the other areas. And even still, Harrison, wouldn't you agree that IMST and EMST in the pediatric population has been far and few between, except for a lot of your work in Pompey's?
Yeah, we definitely don't have we don't have the data in children. We do in adults. Even most of my Pompe work has really been in adults with late onset Pompe, more so than children with infantile onset. We do have a couple of small case studies, but this is often how things go with medical treatments, is that they're first applied to adults and then sort of brought down to children. But it's a real limitation. It's a real limitation.
It's a good point. Well, listen, we can't thank you enough for your time tonight. You've been very generous to give out your email, harrison.jones@duke.edu. Dr. Jones is often on the speaking circuit. We hope to see at ASHA in New Orleans this year, and we always see you on the ASHA Wire giving your talks and just your great work coming out of Duke. And again, mentioning it was really your invention that brought the IA adapter to life. So thank you, Dr. Jones, for your time. And if there's any questions you want to follow up, you can certainly email Dr. Jones at his email address, and you can always reach out to the health professional site on the Aspire website. Okay, folks, let's everyone have a good night. Everyone be safe. Thanks for joining in. Take care.